I personally don't think that that is necessary to do in clinical practice. This kind of a patient, in my opinion, in terms of follow-up, while you could do scotopic microperimetry, the reality is that what you're really worried about for this patient is their risk for developing complications. This particular patient is at high risk for developing type 3 neovascularization, and so that's what really we're monitoring for. So honestly, I don't really do much in the way of functional testing for these patients, but I do look at this as a high-risk phenotype, so I will have to follow them a bit more closely.
Thank you.
Recovery. The recovery trial was a randomized trial of comparing monthly aflibercept versus every 3-month aflibercept to see if that could actually cause a recovery of non-perfusion. It was actually the opposite. There was a thought that because we were seeing with anti-VEGF therapy an apparent regression of diabetic retinopathy, people wondered, can you actually recover the non-perfusion with anti-VEGF therapy? So I can tell you, you can't recover the non-perfusion.
My case is about that.
It's not always due to devascularization. That was the fundamental concept. And in this case, I think that you showed two different types of mechanisms that can produce that. One can be that there could be what we call transudation as opposed to exudation, but essentially that you're having fluid accumulation, as you alluded to, because of poor RPE pump function. We might see this in central serous or some other types of other conditions where the RPE is failing. And you highlighted the case that I mentioned earlier. If you have a big PED, you might see hyperreflective foci because the RPE is leaving as well. But those large PEDs, there can be very poor RPE function over them. You can have fluid accumulation over those PEDs, especially as they're collapsing. And it's not because of neovascularization, like in Marcelo's case where there's a controversy about that. There's just, you can have cases where clearly there's no neovascularization. You have this type of non-neovascular fluid that relates to poor RPE pump function. In which case, you might question, well, if you have no RPE like in GA, why don't you see this then, right? And sometimes you can see some fluid, but most of the times you don't have any fluid. And there, I think it gives some insight into the pathophysiology. You need to have poor RPE pump function, but you need to have some persistent choriocapillaris and the like there. And that's why it can be a transient type of thing. You need to still have a source for the fluid and coming there, and then no pump to get rid of it or send it the other way. And I think in these GA cases, you don't have the benefit of any choriocapillaris. Plus, in GA, one of the things we've seen on histology that Bailey Freund and Christine Curcio have shown is that there's a glial seal that the Mueller cells sort of embed onto Brooks membrane. And I think that also prevents the fluid from accumulating. So I think that gets into these questions. So that's one of the aspects there. But I want to distinguish these entities from RPE function from another question you asked, which is in the patient in the setting of vitelliform disease, whether it's Best disease or this adult onset sort of pattern dystrophy type of vitelliform accumulation. And vitelliform material doesn't always have to be bright, especially in the later phases or especially in the superior aspects of these accumulations. It can be hyporeflective. And I think that's a different mechanism. I don't think that's necessarily poor RPE function. I mean, that may also be contributing, but it may be another reason for why you're getting a vitelliform accumulation. So I think there are two different things in that situation. But one is RPE pump function issue, one is accumulation of material that happens to be hyporeflective. Get into so there's a desire to identify these patients, and you're correct. I mean, the genes like SBCLT and a few others have been identified to be associated with MACTEL. But I will submit that there's still a minority of patients that you can find some genetic risk. So we don't routinely screen these patients for genetics because so many of the cases we don't have the gene identified. I do think that there is evidence to suggest that patients who do, like other family members of a patient with MACTEL, I mean, the reason to do it is really to consider there are other family members who don't have any visible findings. Can you see if maybe they have risk? So that would be the argument to do it, but we currently don't do it so far, routinely at least.
Okay, our next case, this is a 23-year-old female.
That's the only thing I think about. But I do think that, so we've studied this entity as well with OCTA. And the very interesting thing that many people often wonder is, these myopes have very thin choroids, yet they can still see well. And it turns out you can have a thin choroid, but your choroid capillaris can stay relatively intact. As long as it stays intact, these patients see well, they do fine. Eventually, the choroid capillaris, as the ectasia progresses, gets impacted, and then that's when we see the development of neovascularization. So the underlying pathophysiology, whether it's pachychoroid disease, whether it's age-related macular degeneration, or whether it's myopia, the underlying pathophysiology for why macular neovascularization develops seems to still be choroid capillaris ischemia. Which kind of makes sense, because that's why we see neovascularization diabetes, retinal not perfusion. So it's still fundamentally the same pathophysiology. Now, yeah, you're correct. The point that you make is a very important one. We know that in myopia, it's sometimes very difficult to identify activity because you don't tend to have a lot of fluid. And that's where, and again, most myopic neovascularization is type 2, which means it's in the subretinal as opposed to the sub-RPE space. And that means that in the subretinal space, you see this subretinal hyperreflective material, or we call SRINIVAS. And that subretinal hyperreflective material, as you show at the top of the material, when it's an active lesion, has that kind of loose sort of medium reflectivity, and then with treatment, it gets more compact. So we look for the compaction. And so usually, even after it gets compact, we'll treat one more time to make sure it's not getting more compact. And only after we see that there's no further compaction and we don't see any signs of fluid, do we say that we can observe them. And we know that we can observe them after that because we have good clinical trials now, both for ranibizumab and aflibercept for treatment of this condition. And we know on average, most patients only need 1 or 2 injections. So it's actually highly responsive to anti-VEGF therapy.
Thank you. And Marcelo.
So, very good question. So again, one of the things to keep in mind is that, as I said, that the deposits in this AMD condition can appear in multiple locations, including the subretinal space. So now acquired metalliform lesions, or AVLs, are part of the expanded phenotype of AMD. And we recently published that they're not that uncommon. Actually, 10 to 15% of our patients with AMD, when we looked at them, we could identify this material. So we often don't focus on it, but it's frequently present there. In terms of the importance, obviously the importance is that you have a higher risk for development of atrophy or neovascularization, as you nicely showed, your case developed neovascularization. And oftentimes those complications develop as the material progresses. So just like drusen can sometimes go away and leave no atrophy, this can sometimes go away and leave no atrophy. But if you have a larger deposit, or if it's closer to the fovea, we showed that when it goes away, usually you develop atrophy or neovascularization. And so as it starts to go down, you need to start following that patient more closely to see if they'll develop this kind of a complication. So that is a very important point that you raised.
Thank you. Thank you.